Record on computer. Okay. And I'll share my screen. Okay. And then others. Hold on. All right, I'll pull up today's slides. I thought we could start today with a review of just a couple of life cycle nutrition questions and the nutrition care process. So I have a few questions. Let me make my screen bigger. And then if you want to type your answers into the chat, that could work. So the first review question is, what 2 levels does nutrition assessment target? Okay, so whenever you're ready, just type your answers into the chat and then we will discuss it. Okay, good. So everybody had the answers community level and individual level, and that's correct. We learned that nutrition assessment can be applied to both individuals, which we would think typically of our clinical populations. Clinical can be inpatient or outpatient, but when we're working at the level of individuals, we're assessing a person for their own individual attributes in order to provide them with their own individual diagnosis and then create an individualized nutrition intervention that will help meet their individual needs. But nutrition assessment can also be applied at a community level where we have a group or population. Sometimes individuals within groups or populations will have similarities, but of course, each individual likely has their own unique differences that do need to be considered in nutrition intervention. When we're tailoring nutrition assessment for a group, however, we look at what overall group nutrition needs are. So perhaps the population doesn't have access to nutrition education, or maybe it's a low income urban community and they don't have access to fresh fruits and vegetables and would benefit from a farmer's market. Or maybe this population has a high risk of diabetes and could benefit from weight management and diabetes prevention education. So there are different uses for nutrition assessment, both at the individual level and community level, but they can also be applied to the 2 levels. So good. Okay. Next question is, list 4 measurement categories of an individual level nutrition assessment. Okay, good. So, okay, we have responses of clinical and physical, dietary, anthropometric, and biochemical. Of course, it doesn't need to be in that order. Um, yeah, so those are all 4 different measurement categories or different types of data and information you can collect at individual levels, where anthropometric is best conceptualized as body measurements that you can take, such as height and waist circumference and body fat levels, and so other measurements too. Um, Biochemical is typically more like lab values that you would take through like a blood draw. Um, there's clinical signs and symptoms that can be assessed. For nutrition and dietetics, there's something called the nutrition focused physical exam that will look at both clinical and anthropometric aspects. And that technique and approach is really interesting. So for clinical, it teaches people how to assess for dehydration, stomach issues, and other things. Um, and dietary, you can collect dietary information from food frequency questionnaires, food journals, doing a structured 24-hour food recall where a person tells you about a typical day. So great. Those are all wonderful measurements to consider for individual level nutrition assessments. Um, okay, I think I mentioned most of those. Great. Okay, this one's multiple choice. How is healthy people best described? I guess we can just say like A, B, C, D. Sorry. Okay. So responses are B. So I had to reread this a few times myself because I didn't check the answers before class. But I would go with B as well because Healthy People is a national strategy for improving the health of the nation. C isn't the best answer choice because Healthy People isn't our disease monitoring system. We have disease monitoring systems that feed into Healthy People to help Healthy People set its strategy for improving the health of the nation. So it's not actually collecting the data. It's the interpretation and application of data. Healthy People is a national strategy for reducing infection and the disease in the United States isn't wrong, but I think that it's more than just infection and disease. It takes more of a holistic approach to health and considers some other aspects. So B is the best answer choice there. And sometimes when you have multiple choice questions and there might be more than one answer, think through logically as to the best that you can to decide um, what really is the best question for answering, or best answer for answering the question, even though a couple other questions may kind of be okay. So um, good. And do you guys have questions so far? Okay. Next question is describe or just list the 4 steps of the nutrition care process. Okay, so for the nutrition care process, the NCP that refers to the ADIME acronym we were introduced to on Monday. And the ADIME acronym is used to remember and describe the 4 steps of the nutrition care process, which is slightly different than nutrition assessment and the nutrition assessment components, because nutrition assessment is part of the nutrition care process, but the nutrition care process goes several steps further to also include nutrition diagnosis, nutrition intervention, and nutrition monitoring and evaluation. And together, the ADIME comes from the assessment, diagnosis, intervention, and the monitoring evaluation. We talked about how the nutrition care process is it's iterative, or you can think of it as circular. So it's meant to be continuous, and each step helps to move further in the circle, but all of the feedback that you receive along the way helps to inform starting a new reassessment of a patient, client, or population, and then you can start the cycle all over. So hopefully the goal is initially you do your assessment, you provide a diagnosis based on that assessment, or some people or cases have multiple diagnoses. Based on the diagnosis, you design an appropriate intervention, and then you monitor and evaluate how that intervention goes. The intervention can be negative, meaning a person, whatever their issue was, got worse. It could be positive, so their issue benefited, or it could be neutral and maybe they're still stuck in addressing their problem. So based off on that information, you could do a reassessment and say, okay, am I still looking at the same problem? Did the diagnosis get worse? Did the diagnosis improve? So maybe now I need to come up with a new diagnosis for that person to address whatever the next step is. And then you would design another intervention for them, monitor, evaluate, and so forth. So this helps the process be more effective as well as reflective. It gives the field of nutrition and dietetics a way to standardize care, because if we're all using the same or similar processes and mindset, then we can compare our overall nutrition care processes and sit down and say what can be improved in this. So how can we keep continuously improving our patient or client or population care? So it's a really powerful tool. It's been around and constantly evolving for several decades, but the overall general outline of the assessment, diagnosis, intervention, monitoring, evaluation seems to be pretty robust, and that has been the same for a long time. And we also saw that in public health, this framework is used very similarly. It's not always called the nutrition care process, but Healthy People uses it. Dietary guidelines essentially use it. It's basically when you're conducting a public health assessment, you also use a very similar thinking pattern. I know my husband works in uh, more like business finance, and they apply very similar thinking there. In research, you see this type of thinking too. So it's really an approach to problem solving. Um, and in nutrition, we call it the nutrition care process model, and make it more specific to how to actually apply to the field of nutrition. Good. So that was a brief review from last time. Do you guys have questions? Okay. So if not, then we're going to keep talking about preconception nutrition. And we'll probably go to about 11 o'clock again today. Just because we're meeting virtually, I likely won't keep you the whole time. There's a lot of research that shows that learning virtually is ineffective past a certain time point, which is actually kind of like 20 minutes. But of course, then they suggest like break it up, make it more interactive and stuff like that. And that can help people stay engaged more. But I think an hour and 15 minutes is good for us. And then you can use the time when we stop for yourself. I suggest you use it to figure out what you need to do for the class. Maybe make yourself to-do list, look at the Moodle site, make sure you're up to date with everything. You can complete assignments or review any notes, or make some flashcards to help you study. So things like that you could use with that time, or you can do something else. It's your time and it's up to you for your own time management. Okay. So on Monday, we talked about how adequate health and nutrition status are needed for successful reproduction. In otherwise healthy individuals, the reproduction process occurs smoothly, but any disruptions to health can diminish reproductive capacity. And we learn, however, for healthy couples, they do have only 20 to 25% chance of conception within a given menstrual cycle. So it's important as a healthcare practitioner to keep in mind that even for healthy couples, it could take at least 4 months. Usually they say about 4 to 6 months to conceive, and that's okay. That's normal. What When healthcare practitioners start considering if there's any infertility or underlying health issues that might be interfering with the ability to conceive, usually that's about 1 year, 1 year out of actively trying. See, we discussed a couple of complications, including miscarriage. There's something called subfertility. That's not quite infertility, but people have less of a chance of conceiving, or if they do conceive, of carrying the pregnancy. And that can be because of a variety of reasons, including genetic. It could be physical, abnormal struc- structure to the uterus can make it difficult for once the um, egg implants into the uterus. If there's any abnormal structure to it, it might have difficulties growing. There can be sperm abnormalities and infrequent ovulation, which can be directly tied to undernutrition and also disordered eating. Healthy people, the 2020 is in your textbook, has national related objectives for preconception. I'm just going to go see on the Healthy People website what, let's just take a peek and see what they are. No, we didn't do that during last class, so I thought we could do that. So I Google everything. That's pretty much my go-to. I do use, well, so this is actually the Edge browser, the Microsoft Edge browser. I recently switched from Chrome to Edge when I got my new laptop. There's a lot of similarities. So I think the default is Bing. Oh, I'm actually using Bing right now. So Bing is pretty good. I think it's gotten a lot better and closer to Google over the past year or two, but Google tends to give me better search results. But either way, I'll use some sort of search engine, whatever you prefer, and just type in like Healthy People 2030 and it pops up. So let's see if we type in preconception, what happens. Family planning and workshop, maternal work group, topics, objectives, evidence-based resources. All right, that wasn't very helpful. Let's see. Increased proportion of women who are at a healthy weight prior to pregnancy. Okay, here's MICH 13. Let's see what happens when we click on it. Increase the proportion of women delivering a live birth who had a healthy weight prior to pregnancy, who are at a healthy weight. Interesting. All right, so maybe this website isn't as easy as I was hoping to find the objectives. Let's see, browse all objectives. Health conditions. pregnancy and childbirth general, reduce the rate of fetal deaths at 20 or more weeks, reduce preterm births. A lot of these are pregnancy, increase early and adequate prenatal care. Okay, so here's a few family planning ones. Reduce the proportion of unintended pregnancies. Reduce the proportion of pregnancies conceived within 18 months of a previous birth. Reduce, that one's interesting. Reduce pregnancies in adolescents. Increase the proportion of women at risk for unintended pregnancy who use effective birth control, and increase the proportion of adolescent females at risk for unintended pregnancy who use effective birth control. A couple. So, increase the proportion of pregnant women who receive early and adequate prenatal care is important. 76.4% of pregnant females receive early and adequate prenatal care. The target's 80.5%. So almost 25% of pregnant females were not receiving early and adequate prenatal care, which is a huge problem because as we go through this, we're going to learn that a lot of the critical growth and development actually occurs in the first 12 weeks. So preconception nutrition and early pregnancy nutrition, including even something as basic as making sure people are taking a prenatal vitamin or at the very least getting enough folic acid, either in their diet or through supplementation, is really critical. And if they're not meeting that, then there can be some issues. There can actually be some issues with the developing fetus based on that. So early adequate care is important, and we know that it's a predictor of more successful pregnancies. So I'm glad to see that on there. I'm going to explore that more. It looks like they did change them a little bit, but for now, just have the general idea of what some of the goals are, and at least that there are actually goals for preconception, nutrition in healthy people. I'm going to go through this as a review because we talked about it last on Monday, but just to repeat a few things, we learned that menarche occurs around, so the start of a woman's menstrual cycle usually starts around ages 11 to 14, and there are variations. Some women have it occur earlier in childhood, some might be a little bit later. Gymnasts and other elite athletes, female athletes, tend to have very delayed menstrual cycles because of their strict diets and exercise regimens actually delay it from occurring in them. And many of them face disordered eating as well. So that's another area that often needs addressing and is of interest to some people. And we'll talk more about that during adolescent nutrition. And then menopause occurs around age 50, but there's also a variety of, or a wide range of ages that it can occur. It can occur much earlier. It can occur in the 30s, if not even earlier. I think there are a few conditions or diseases where menopause happens really early, and women aren't able to conceive for that reason. And it can occur later. We hear stories in the news of women older and older that are conceiving and having healthy pregnancies. But usually around age 50 or so. And then the period between when menstruation starts and when it ends is the female reproductive years. And a typical cycle we think of as 28 days, but again, that also has variations. It can be less and it can be more. An education on, if you've ever heard of the term natural family planning, it helps women learn how long their menstrual cycles are so that they can monitor when the period of, or a time in their month when they're more likely can conceive. So if they're actively trying to conceive, they they can try then. If they don't want to conceive, then they can avoid intercourse then. Let's see, I had a question. It's mentioned that conceiving after 35 is risky. Is that true? So this has been true for up until I would say very recently, and they still do consider after 35 you're at higher risk of things, including some genetic abnormalities to the fetus. I think you are at greater risk of having a miscarriage. It might be harder to try to conceive each cycle. So that 20 to 25% chance, I think, increases after 35. The chances of having chromosomal abnormalities such as Down syndrome and related things increase after 35, but more and more women, and I don't know the statistics offhand, are now having babies after 35, and there's a lot of healthy babies being born. So I think that with the advances in medical care, things are definitely improving and it is becoming less risky, but it's actually so modern that I'm not even sure how much data is out there about it, but they were calling pregnancies after 35 geriatric pregnancies. So you can imagine that women who were like, 36 and pregnant were like, I'm not geriatric. This is insulting to me. So I think they recently did change it to advanced, what was the term? Like advanced maternal age is what they're calling it now. If you're after 35 years old. So there's definitely risks, and a woman older than 35 and pregnant will likely have some increased monitoring, maybe increased tests. There's the new blood test now where you can get all the genetic testing done through blood as early as 10 weeks to see if there are any abnormalities. You can also learn the sex at that time if you want. So there's definitely a lot of scientific and technology improvements that are allowing women to conceive more safely after age 35. You guys have any comments on that? Okay. Okay, so this table is in the textbook. It's table 2-2. Just gonna take a peek in it. And so be familiar with these hormones. Where is it in the textbook? Okay, in mine it's in this blue one, it's on page 54. So do know the hormone name. I would be able to recognize the abbreviations, at least the source. So know that, for example, gonadotropin releasing hormone is released from the hypothalamus, and then know the action. The action in this case is to stimulate the release of follicle stimulating hormone and luteinizing hormone. And then similarly, know that follicle stimulating hormone, the source is the pituitary gland, and know that it has several actions, including it stimulates the ovarian follicle growth and maturation, and that's the process needed to select an egg to be released. It's also responsible for estrogen secretion, endometrial changes, characteristic of the first portion of the menstrual cycle, and I think I have male reproductive system in a chart a few slides down, but it also stimulates sperm production in males. I have the question. I just got another question. Why do some women have pain during the menstrual cycle? There could be multiple reasons for that. And one of them is the development of a cyst, which can form, I think, sorry, don't quote me on this, but I think that a cyst can form when a woman is trying to release the egg, because the follicle, if you think about it, it matures and it gets bigger and kind of swells. And if there's maybe some hormonal regulations or structural issues, then it might mature and not release the egg and stay swollen like a cyst, and that can cause pain. Um, Ovulation itself is kind of like, so my friend, I worked in a lab for a year with an OBGYN. So I did learn a little bit from her, and she would explain ovulation pain like the follicle matures, and then when it releases the egg, it literally like shoots it. So she would always go like that, like it just bursts. And that causes that in itself is painful, because the follicle ruptures every time it releases an egg. And some women are either just experience more pain, um, they're more sensitive to it, or they actually have more pain from that process. And then cysts can form also after, I think after ovulation, cysts can form as well. Um, so why do some women on birth control have pain if the pill evens out hormones and suppresses ovulation? That's a great question. I'm not 100% sure why that might occur. I would say, I guess if ovulation is suppressed, then it's probably not going to be related to the follicle releasing the egg, or maybe it could be. So maybe it could be due to other issues. Some women have polycystic ovarian syndrome, where they have just multiple little cysts. And I don't know, not, it's nutrition, so I'm not OBGYN area, but I know that that can be painful, and birth control can help reduce the cysts that they develop, but it doesn't always take them away. So they could still have cysts. Um, Endometriosis could be another reason, where the endometrial lining is in other parts of the reproductive system, for ends up in other parts for in the reproductive system, and it can cause scars and adhesions, and they can do oh my gosh, laparoscopic surgery to help fix it, but that can be painful as well. And I think birth control can help with endometriosis, but people can still have pain. There are fibroids. I don't know much about fibroids, but I think there are definitely other issues, not always related to the ovulation or the follicle maturation, that can happen and still cause pain. So, in which case, then if birth control still isn't working to take away the pain, then other interventions, either with the birth control or maybe stopping the birth control and trying something else, might be better. But for that area, you would go see an OBGYN. But the process of the follicle maturation and ovulation, where the egg is actually released, in and of itself can cause pain. Let's see. So for those are great questions. So please feel free to ask. I'll try my best to help you. One thing I found interesting too, that my friend Sarah, who's an OBGYN, told me, was that ovarian cancer, one theory behind it is that when the egg is released and the follicle tears, the follicle has to then repair itself. And if you look in the book on page 53, you see the maturation process of it, um, or the ovary has to repair itself when once it bursts, and then it kind of like it needs to repair itself to heal itself, and then the follicle can go through the maturation cycle again when it needs to. And in that repair process is when cells are essentially shed and then they have to be fixed. And some cancers can form, ovarian cancer can form in some people that are susceptible to it during that repair process, because over time the repair, something goes wrong in the repair process, and then it keeps repairing itself in a negative way, which can eventually form a tumor. Um, and that's why it's thought that birth control or having pregnancy, multiple pregnancies, also breastfeeding, which delays ovulation. So anything that would make you ovulate less is shown to be preventative against developing ovarian cancer. And one of the theories is just because it's reducing the amount of times you have to go through the bursting of the ovary to release the follicle, and then the repair process of the ovary. So anytime ovulation is suppressed, which can happen through birth control, pregnancy, and lactation, they do see some reductions in ovarian cancer among women, or at least delays in it. So, all right, I have another question. Why do some women, even on birth control? Oh, no, wait. Regarding birth control, I've been hearing, I'm not up to date with birth control, by the way. So I'll try my best, but I've been hearing it can cause deficiencies in micronutrients and something about high copper levels. So does it have impact on conceiving when a woman gets off of the pill? I don't know that 100%, but I have heard of deficiencies in micronutrients, which is interesting. Could be a good research topic. Um, and if it did cause deficiencies in micronutrients, then if a woman were trying to conceive, I would think that they should then go on like a prenatal supplement, stop the birth control and go on a prenatal supplement to hopefully help address any of those micronutrients. So to help increase their chances of conceiving and also just make their pregnancy healthier. For most women, they need to go off birth control, and then it takes them a couple of cycles to kind of get normal and to be regulated before they can conceive. So it's always good if you're actively trying to conceive to go off birth control a few months before you would actually like to. And then with the copper, I'm not sure about the hormonal birth controls, but there is a copper birth control that can be inserted. And maybe that, I don't know if that's what you read, is causing higher copper levels. Some people are sensitive to copper, so shouldn't use that form of birth control. But that's interesting. And I'm not sure about the repercussions of if you do a copper related birth control and then go off of it, if it impacts their chance of conceiving. I think I've heard more of women using like the copper birth controls after they've had their pregnancies and just don't want any more children. I'm not sure of reasons why, or the frequency of people using it before they conceive. So I'm not really sure about that. That's a good question. Okay, so yes, be familiar with these hormones in the chart and their sources, and then their actions. Um, there are two phases to the menstrual cycle. There's a follicular or a proliferative phase, and then the second phase is luteal. So, as far as terminology, let me just look at the diagram for 1 second. The main concept for this is to know that there's a follicular phase, which is the beginning of the cycle, And then the luteal phase is the second half of the cycle. And we can see that here in this chart, which I'm going to show large. So these are how hormone levels are influenced during the menstrual cycle. There are changes in the ovary and uterus that occur, and these changes correlate with changing hormone levels during both the follicular, so the first half, and the luteal phases, so the second half. Being aware of how those changes in the ovary and uterus correlate with the hormone levels is important to nutrition, because nutrition can alterate hormonal levels. And if there's issues in hormonal levels, then that can feed back into causing issues in how the ovary and uterus change in preparation for conception. So we'll go through this. In the brain, we have glands that secrete hormones, and that occurs through here at this kind of right off the brainstem. Here is the hypothalamus, as well as the pituitary gland. You're going to hear these again when we talk about pregnancy and lactation. So they play an important role in trying to conceive, as well as during pregnancy and during breastfeeding too. The hypothalamus releases gonadotropin releasing hormone. I'm just pull up my chart 1 second. From the hypothalamus, and then that stimulates the release of follicle stimulating hormone and luteinizing hormone. These hormones are responsible for stimulating the follicle maturation. And let's see, the follicle, needs to, where's the follicle in the book? Just wanted to find a definition of follicle to read for you guys. I don't even see one in the book. Fertility. Anyway. Let's see. Anyway, the follicle needs to mature. And that's right here. And that's inside of the ovary. Okay. And then the follicle matures, and then estrogen is secreted. And then we have, so you have FSH here, which is released, and it stimulates luteinizing hormone. So you see an increase here in blue. And then both of them peak about midway through the cycle. So if you think of a traditional 28-day cycle, that's around day 14. But of course, that's just textbook numbers. So there will be variations in individuals of when that day occurs. Then you have the surge. So then you see after that surge, once the follicle is released from the ovary and ovulation occurs, then those hormones drop back down. Let's see. So the follicle matures, which stimulates release of estrogen. And estrogen, then we see this increase in the blood. And estrogen also tends to have a peak it's kind of right before the LH surge occurs. And again, I think I briefly mentioned on Monday that if people use an at-home ovulation test, it's testing the FSH and LH triggers, at which point an egg is released, the ovulation occurs, and then now we move into the luteal phase. So if you look down here, it has follicular phase and then luteal phase. And also, as all of this is occurring, there's changes in the uterine lining. So menstruation is when the uterine lining is shed each month because there was no implant, there was no implant, so it wasn't needed. The uterine lining actually is very rich in blood and nutrients. So when a egg, a mature egg does implant, if it does implant in a uterus, it has all of the nutrients and blood supply that it needs right there through the uterine lining. So we see that also an increase in the uterine lining throughout the cycle. And then once the body realizes that implantation isn't occurring for the cycle, it will shed the uterine lining, and then the cycle will start again. So we see our peak in estrogen, and then an egg is released. And from the follicle, so an egg is released, ovulation occurs, and now we move into the luteal phase. Now, if a person conceives at that time, then from the follicle, and why the follicle is important, a corpus luteum will emerge, which is shown right here. And this corpus luteum is responsible for secreting large amounts of progesterone and some estrogen as well. This inhibits, if we go back up here, it inhibits the gonadotropin releasing hormone and also inhibits FSH and LH. So it's providing negative feedback to decrease those. So you see a drop in those hormones, and you see estrogen shoot up there. And then, so in very early pregnancy, the corpus luteum provides progesterone, which is needed to support growth of the embryo. Sorry, it's called an embryo at this stage. So it supports the growth of the embryo. If some women who are having trouble to conceive, one reason might be that when their corpus luteum forms, they're not producing enough progesterone for whatever reasons. Again, I'm not an OBGYN, but I know that can be an issue. And then one way that it gets resolved is if they take progesterone, as exogenous progesterone as hormone therapy. If the egg is not fertilized, though, the corpus luteum will break down and menstruation then occurs. And if an egg is fertilized, the implantation period usually occurs 8 to 10 days after conception. And then, if all goes well, that can result in an embryo. And usually around 6, 7, 8 weeks, people find out that they're pregnant, which is why you're already halfway through your first trimester and you may not even realize you're pregnant. So having proper nutrition while you're trying to conceive is really important. And even just having populations that have adequate health and nutrition, even if they're not trying to conceive, that are still in fertile female years, is important to reduce any risks associated with nutrient inadequacies during the first trimester. So if you have a population that doesn't have too many nutritional inadequacies, and people will naturally conceive it even if they're not trying or planning for it, then those pregnancies have a greater chance of success. So nutrition is important to support a healthy pregnancy, but it also has important roles in allowing a person to conceive too. So I suggest you be familiar with this illustration. Read the section definitely read over a few times the description of it in the text, and be familiar with the terms and the process of the hormones. There's another nice chart or illustration in your book, illustration 2.3. I don't have it in these slides, but it's on page 55 of your textbook that shows how the hypothalamus, in more detail, how the hypothalamus secretes the different hormones, and it goes through some of them. Let's see. Oh, sorry. This is for the male cycle, sperm production. So there's a good illustration. Well, it's good to even just visualize the hypothalamus and how it's secreting the different hormones. But then it goes into sperm production. So that's good for showing how hormonal activity is related to sperm production, but I don't have that chart here. I just have a couple of slides on reproductive capacity in males, which is important. One thing to know, a big difference is the male reproductive system is ongoing. It's not cyclical. So the process of spermatogenesis or making sperm can happen. It happens ongoing and continuously. It doesn't happen in a monthly cycle. And there are hormones, including testosterone, that help to stimulate sperm, and gonadotropin releasing hormone, follicle stimulating hormone, luteinizing hormone, and we mentioned testosterone, are all important in the male reproductive cycle. So be familiar with those hormones as well. Let me see. And there are similarly those, you have the hormone regulation that essentially tell the body to produce and stimulate spermatogenesis. So if there are any issues in those hormones, which can be impacted by nutrition, then that process can be interfered with. Weight loss and weight gain can be complications that interfere with both reproduction in male and women. Inadequate vitamins and minerals, having excessive body fat, especially center around our bellies, can interfere. Having not enough body fat can interfere. Advanced age can be a risk factor too for both men and women. So being over 35, although we are seeing more and more people over 35 conceive and have otherwise healthy pregnancies. Some medications can interfere with male and female reproductive cycle, as well as some psychosocial factors, including stress. Stress can interfere with our hormones and reproductive cycle as well. Nutritional factors generally exert a temporary influence on fertility. So if the nutrition is corrected, normal fertility can return once that problem is fixed. And some pre-existing conditions that are nutrition can be managed with nutrition, or at least including nutrition in part of the medical management, include eating disorders, diabetes, hypertension, PCOS, as well as other autoimmune diseases, including celiac disease. So for weight status, for underweight women, if they have a low body fat, this can interfere with the release of follicle stimulating hormone and luteinizing hormone. And as we just saw from the chart, if FSH and LH aren't released, just go back from the pituitary gland, then you're not going to have this surge. So just imagine if this stayed flat. Oh, you can't see me point. If this stayed flat and there's no peak, there will be no ovulation. So that's one of the main drivers behind why people who are underweight or who have eating disorders that are causing them to be underweight, or elite athletes, have issues conceiving or ovulating because of their FSH and LH hormones. For obesity, it can impact fertility for men and women. And one of the reasons is insulin resistance. Insulin resistance has been associated with cardiometabolic syndrome, which can include diabetes and cardiovascular disease, as well as polycystic ovarian syndrome, which I briefly mentioned, which is where women form multiple cysts on their ovaries. I think there could be multiple reasons why that happens, but those can all interfere with, if you have multiple cysts on your ovaries, then that can interfere with that follicle maturation, which is also needed for ovulation. So obesity can interfere with several hormones, including estrogen. And if we go back to our chart, then we see that estrogen here is needed because it helps to stimulate. Estrogen, hold on, where's our estrogen? Rise in blood estrogen is the green. Estrogen is needed to increase changes. Oh, I think it supports the changes in the uterine lining. So it promotes the uterine lining maturation, which is needed. And it also inhibits, eventually, estrogen, progesterone will inhibit the LH and FSH, which need to go back down to help the corpus luteum do its job of secreting large amounts of progesterone to sustain pregnancy, and obesity can interfere with that process. Let's see. Excessive body fat and fertility, importantly, are more likely to be less fertile. Inadequate body fat and fertility are also more likely to be less fertile. Because while too much body fat can interfere with fertility, we actually do need a certain level of body fat. Body fat is related largely to estrogen production, and that's needed to conceive. There's also undernutrition, which is associated with dramatic declines in fertility. Undernutrition and malnutrition can be treated with nutrition intervention, and usually fertility can recover when food and nutrition status are improved. And from an epidemiologic perspective, we've seen food shortages are associated with dramatic declines in birth rates. Areas where malnutrition is prevalent also tend to have declined birth rates. So undernutrition, malnutrition aren't always necessarily associated or present with not enough body fat. They can be associated with not enough body fat, and then all of that needs to be addressed. But you can also be of normal weight and still have nutrient inadequacies, but still be within a normal weight category. But having a caloric deficit, so not eating enough calories, can also impact your chances of conceiving, because it all relates back to the FSH and LH cycle. Weight loss, especially rapid weight loss, can impact LH and FSH as well. And that can result in amenorrhea, which is an ovulatory cycle where a person isn't ovulating, as well as short or even absent luteal phases. And there is a fertility drug. It's called Clomid to help increase fertility. It doesn't improve fertility until weight is actually regained, which is interesting and shows the importance of having a healthy weight when a person is trying to conceive. So let's see, I think I'm going to stop there, and then we'll talk about a couple of specific nutrients on Monday. And we'll talk about nutrients, how to ensure adequate nutrition during preconception, and then talk about a couple of different conditions and more details about body weight on Monday. And then let's just review the schedule. So just remember to review chapters 3 and work on your paper topics, which I changed to be due next week. Which is, let me just check my calendar. Let's have them due on Wednesday, the 10th. I think that's fine. If you already have your paper topic, you can email me. And then otherwise, if you want to wait till next week, that's fine. And I'm going to open the Dropbox on Moodle after class today. And that's all that's due for now. So just review course material, do your focus on your paper topics. And for exam 1, I'm going to use there's a proctoring service I signed up for that the college is offering, but I don't know what that means. And it's online somehow. I don't know what it's going to look like. Monica said, or Professor Luby said that it's either I could either do that or I could do where, right, you're taking the tests and you're also Zooming so I can see everybody, but she thinks that the proctoring service might just be easier. So let's just go with that. And that will be for the exams. So 1-3, sorry, next week is the 8th. Hold on, 1-3. Did I do then 8 and 10? And then 15 and 17. Okay, so exam 1. Let me see. I'm just trying to think if maybe we should push it to the 17th. Would you guys be okay with that? If we push exam 1 to the 17th? Okay. I tried my best with the schedule this semester. Remember, I think we lost 2 weeks, so we'll have to just be a little bit flexible with everything. But I think the 17th might be better. And it will still cover the same material. So lactation will not be on exam 1. It will be nutrition basics, preconception, and nutrition during pregnancy. And it will only be nutrition basics from the PowerPoint presentations. It won't be everything in the chapter or on the practice quiz that you took that was on Moodle. So just focus on what's in the PowerPoint slides for the exams. Do you guys have any questions?
Yeah, for the topic, the paper topic, do we have to write like something about it?
A brief paragraph. I'll post the details as soon as we're done with class. But it's basically just a brief paragraph, like why you're interested in the topic and why you chose it.
Okay. Thank you.
You're welcome. Okay, so if you guys don't have questions, you're free to sign off. I'll stick around for another minute, and thank you all. I hope you have a wonderful week and enjoy your weekends, and we'll meet again on Monday.
Thank you, Professor.
Thank you.
Thank you, Professor.
Bye, thank you.
Bye, you're welcome.